Well, hello and welcome. I'm Sandy Morgan. I'm an OB-GYN from Michigan, and I'm going to be moderating today's session. We're talking with Dr. Rachel Langley. This is direct primary care, how cutting insurance out of your practice makes for better physician mental health. Dr. Langley served for 12 years in the Air Force as a flight surgeon, but moved to Germany and separated from the military to join a DPC, a direct primary care practice, in September of 2019. She still serves in the reserves so she can keep flying in F-16s, but searching far and wide to find the perfect practice, this was it. She's a mother of 5 and married the best man she ever met, which is excellent. And the only thing that could pull her away from home every morning is her love for medicine. After attending CU Boulder and a short stint as a middle school science teacher, she couldn't resist medical school any longer and attended osteopathic medical school in Kansas City, KCUMB. The Air Force brought her to Las Vegas for residency in family medicine, then to Oklahoma to fly with student pilots. Dr. Langley enjoys gardening, bonsai, beekeeping, reading, and travel. She is certified as a lactation consultant and a medical consultant in NAPRO technology. Let's welcome Dr. Langley.
Thank you for having me. I don't know about you, but when I was in high school and college, when I told an adult or a mentor that I wanted to be a doctor, they would tell me to find a different career. That medicine, even in the 90s and the aughts, wasn't what it used to be. There wasn't the pay. There wasn't the prestige. It was becoming harder to be the doctor that you dreamed of being. And that was even before EMRs and all that clicking. Apparently many of my generation had the same experience, but here I am, a doctor. Personally, I became a middle school teacher directly out of college because of this. I taught math, science, religion, and computers to 6th, 7th, and 8th graders in a small Catholic school outside of Denver. I loved it, and I still keep in touch with many of my students, but it wasn't enough. I still ended up trying the MCAT just to see what I could do. And then I applied to some medical schools just to see, and interviewed just to see. And right away, I saw that ND schools weren't as interested in me because I had wavered in my commitment in medicine to being a teacher first. That was my first introduction to the concept of moral injury. Because of my desire to expand my horizons, I was lesser of a candidate to becoming a doctor. But I didn't hear about moral injury for a long time. What I did hear about was burnout, and resiliency is the solution to burnout. But let me take a step a little bit further back. Sit for a minute and think, what do you think of when you say to yourself, I'm a doctor, I'm a nurse practitioner, I'm a PA? Maybe a sense of pride. It's a noble profession with high ideals. Some embarrassment. People think I make so much money, and it's not what it used to mean. Some satisfaction. I worked hard to be here. A lot of exhaustion. I am never done working. I read these letters from St. Francis of Sales over Advent last year. I was really struck by the way that he desired to combine a work life with a spiritual life. And I was surprised at how difficult it was for me. I'm a doctor. I save lives. Shouldn't a Christ-like interior be easy for me to achieve? So back to my story, after the NU schools were less than thrilled with my work as a middle school teacher, I went to a DO school and got a military scholarship. But now I had this monster in my closet, this elephant in the room that I was watching for. Everyone knew doctors were miserable. Why? What made them that way? Why didn't doctors get to be the noble, brilliant heroes that I had dreamed of being? And how could I avoid that? Not only avoid it for my own well-being, but it turns out that burnout impacts my patients as well. When I am burnt out, the last thing I can express well is empathy. And apparently patients respond even with their cold symptoms when a doctor is more empathetic. But that's hard to balance when I am the face of the healthcare system. There's an amazing New York Times article that I'll show you in a minute by A.L. Press called The Moral Crisis of America's Doctors. In it he says, doctors are increasingly the scapegoats of systemic problems with the healthcare system. Because the patient is not seeing the insurance company that denied them the procedure. They're not seeing the electronic medical records that are taking up all of our time. They're just seeing the doctor who can only spend 10 minutes with them in the room. Or the doctor who says, I can't get you this medication because it costs $500 a month. And what ends up happening is we internalize that feeling. That feeling of failure, wanting to help people but having our hands tied by the systems that are supposed to be enabling our care, making it more affordable. I swore to care for my patients, but I'm not able to because of the insurance company. They said no. I only had 10 minutes with them. And the medication was denied. And that failure feeling is what is now being called moral injury. When I had heard of burnout, it seemed like burnout was your fault. You didn't do enough yoga. So I was going to avoid burnout. I chose to go to the only school I interviewed at where the students seemed happy. They had enough time to do extravagant things in their spare time, like exercise or hang out with their friends. And then in residence, we talked about burnout again. And it seemed very punitive, very your fault. We had bailiffs for prescribed group therapy sessions, in your spare time in residency. Or you could take this 8-hour computer-based training that will teach you, it'll teach you to lie on the resiliency tests, to shut up and color. Because it turns out that at least in some corporate jobs in your future, those resiliency tests are sometimes used to identify the outliers of burnout and get rid of them. Because who is more likely to make a mistake and attract litigation than someone who's burned out? How sad. Although I'm sure many folks are failed out of residency for good reasons, the only example I watched in my residency seemed more tragic than anything else. Tracy was a little withdrawn from the rest of our cohort from the beginning. And when she was in the last throes of edging towards being kicked out our intern year, she made a remark that could have been seen as suicidal. Honestly, the rest of us had made similar remarks to it every day, but she was targeted due to her situation. She was held on a psych holding voluntarily for a few days, and then they asked me, apparently the closest thing she had to her friend, to go pick her up and drive her home with our mental health liaison when she was released. She didn't seem less distraught about her situation. She hardly looked at us. And I'm not saying that being extra cautious with her to keep her alive wasn't the right thing to do. It was a difficult and awful situation all around. But it was another time when I was taught that reasonable expressions of the ups and downs in mental health, when it comes to doctors, is unacceptable. Frustration and anger need to be locked up, because if you let them out, you might very well lose your job. So the definition of burnout didn't sit well with me, but that's what I named my talk because personally I only heard of the concept of moral injury in the last year or so. As we have seen our patients time and again, being able to name your disease brings clarity and peace. Moral injury was first termed to describe the unique variety of PTSD that was seen in a lot of Vietnam vets. The injury some of them suffered had more to do with what they were asked to do by leadership that was contrary to their morality than necessarily being in mortal danger themselves. They realized the source of these symptoms was the fact that they had had a moral code and they were forced to violate it. That caused real harm. And I find that so powerful, so applicable. The more I think about it, the more examples I find in my own life. The source of their symptoms was the fact that they had a moral code and they were forced to violate it. From the time that I got in trouble in residency for shouting at my own rare female attending because she was clearly more interested in going home that weekend as soon as possible and letting my OB continuity patient to labor as she needed to, or all the low-income OB patients that I saw downtown who might have delivered vaginally on their own, but were C-sectioned, maybe for a higher hospital profit, maybe because the OB wanted to get home. It was tough to see. I saw my fellow family medicine doctors going through, whether military or civilian, and I chose to do something slightly different. I was a flight surgeon. I provided top-notch care for aircrew, pilots, air traffic controllers, and their families. You know, they're critical to the mission. They had specific health requirements to meet that I had to be aware of. So there was more time built into my schedule to visit with them. I also got to do extra things outside of clinic to build their trust, like visit the air traffic control tower. How cool, like going up in an F-16. Now this article went viral in 2018 because it resonated with so many doctors. The moral injury of health care is not the offense of killing another human in the context of war, it is being unable to provide high-quality care and healing in the context of health care. There's a quote from it. And those authors went on to write this book, which kind of expands on the instances of many doctors facing moral injury and suffering. I really like the name of the book. It actually comes from a certain translation of the Hippocratic Oath. The end of it goes, I pray that the attention I give to those who put themselves in my hands be rewarded with happiness. And in honor of the knowledge I received from my teachers, I swear to care for anyone who suffers, prince or slave. If I ever break this oath, let my gods take away my knowledge of this art and my own health. Here speaks a citizen, a servant of people. May I be destroyed if I betray these words. So many of us hardworking doctors are not being rewarded with happiness, to say the least. We are trying to be true to our word and work for healing, but our efforts keep being thwarted. That is breaking us. I saw my peers inside the military and out being pushed to see more patients, create more RVUs, finish more detailed notes with more checkboxes, into late into the night, and then asked to come to work early to attend the newest required meeting, the newest opportunity to become the champion of a health issue. You too can be in charge of tracking the passenger numbers for the facility so we can report them to the powers that be and can be listed on the good kids list. Play stupid games, win stupid prizes. I wanted to provide great care for my patients, but that's not the way I wanted to do it. I wanted to have long enough visits to talk about why they weren't getting their pap smear. Was it the cost? Was it fear? Was it bad experiences in the past? Let's hash that out. Let's see what I can do to help you to get there. Not just mark them in the tally of bad patients. But what can be done in the situation we're in? I knew I wanted to separate from active duty, settle down in Colorado Springs with my family, be near both sets of grandparents. But I didn't want to sign on with a hospital system, and I didn't know the first thing about starting my own business. I happened to think of the smartest man I knew, a mentor from residency who had retired from the military. I learned he had started a direct primary care practice in Idaho, and that was the first time I heard of DPC. Some studies indicate that if you are in charge of your own clinic, you are happier. And that was interesting, but not what I wanted. I Googled the DPC practices in Colorado Springs and actually picked one out because in the list of procedures that single doctor performed, it mentioned IUD removal, but not IUD placement. I figured I might get along well with him. I contacted the clinic, I interviewed with the doctor, I was stationed in Germany at the time, so it was extra interesting to interview. But when I moved to Colorado Springs, I was set to learn DPC by working for a doctor who'd been doing it for years. It was great. I had never experienced an independent medical practice. Which is interesting, because 30 years ago, 75% of primary care practices were independently owned. Now it's flipped, and only 25% are. I think in part, we have come to believe that our time is better spent with patients. But is that really altruism, or is it our pride? Is it our pride preventing us from being in charge of the little things of owning a business? We're too important to do those nitty-gritty things, billing, following up on overdue charges, and let other people take over. I mean, our vanity even prevents us from connecting with other physicians and discussing our worries, our mistakes, our failures. In part because we aren't the bosses anymore, and we are afraid of losing our jobs for making a mistake. So we're a lot less likely to talk about them with our peers, to the detriment of our own mental health. Our pride stops us from getting help that we need. I learned all that the hard way. After 3 years of working for this tiny DPC practice, I was in discussion to gradually buy in, to become a partner, and eventually an owner when the current doctor retired in a few years. But the price was exorbitant. When I thought we were still in the middle of negotiating the terms, he came to me and told me, "It's time for you to start your own practice." He was laying me off and hiring a less expensive nurse practitioner. So there I was, 30 days left of receiving a paycheck, the sole breadwinner for a family with 5 kids and a mortgage. I had to make this work. I could sign up with the hospital system and I'd get a reliable big paycheck. But then this talk would be pretty lame. We aren't still here in this evermore situation of healthcare for lack of trying. This is an interesting quote from the New York Times article. We're trying to MacGyver our way out of it. And so I did too. I built my own website. I got a mentor from the local small business development center. I looked desperately for a grant. I'm a woman, I'm a veteran. Someone wanted to give me money. No. I got a good loan. I worked late, came in early. I didn't see my family much for 2 months. And when I was with them, I talked a lot about what I was doing and why. This gave me more courage to face every day than anything else. It was a good chance to show my kids sometimes you have to work hard and suffer for your dreams. Sometimes doing the easier and expected thing isn't good for your soul, for your mental health. One day we'll look back at this and laugh that we ever doubted. When you feel God's pull, He won't let you down. My kids have done a lot of shredding documents, scraping Goodwill stickers off of furniture, and helping me to get my office ready. And we opened our doors on August 7th, 2023. It turns out that if you cut health insurance out of a small practice, between the special EMRs for coding, the personnel whose whole jobs it is to correct our terrible coding, you can cut overhead by 40 to 50%. That is huge. So let's run some basic numbers. Say your clinic has to make $400,000 for your middle area salary, maybe an employee to some supplies and some overhead. And let's say you choose to handle 600 patients, which is pretty average for a DPC practice. How much would those patients have to pay monthly? Would it be reasonable? So $400,000, type into your phone, divided by 600 is $667 a year, which is an average of $55 a month. Now you can maybe give discounts to big families, I do. Make it less expensive for additional kids, make it a little bit more expensive for retirees with complicated health histories and medical issues. But $55 a month average is doable. Here's another way to depict the change from the typical insurance-driven model of healthcare to DPC. It's an image about how the care goes. So blue is the provider, the yellow is the patient, red is the insurance folks. There's a whole lot of red insurance double checking and being involved along the way. Whereas with DPC, it looks more like this. You have more time to talk about the costs with your patients. Instead of trying to get a hold of the insurance companies to get an idea of what the code is, to see what that code would apply to in your hospital, you already have contracts in place with the local imaging centers to know how much an x-ray is going to cost or cash. You've already upped your phlebotomy skills, like I have, and you draw your own patient's labs right in the house with a contract with Quest or LabCorp to come and take it away, get results back to you the next day, and at a tenth, literally a tenth of what insurance charges for those labs. You might even have some basic meds on hand to dispense, a godsend when your patient comes in feeling crummy with strep throat and would rather not wait at the pharmacy. They're gonna love you forever for that. Patients really do love it. They love that it's a one-stop shop. They love that you have more time with them. You can get them in sooner because you have fewer patients. You get to spend more time with them. They love the confidence that they gain when they realize that they can call you after hours, text you on the weekend, send you an email, and actually reach their very own doctor. So that's what direct primary care looks like. Thousands of doctors across the country have been doing it for years and are doing it well. They call it direct primary care because you're working directly for your patients instead of working through insurance who pays you. There's no middleman. There's no question of who the paycheck is coming from, who deserves your loyalty, whose rules you have to follow. Now, there are certain gut reactions that doctors tend to have with this information. They worry they're gouging their patients. They want to take care of these people. But I'd like to point out that that's not something that the large healthcare insurance companies seem to have qualms about. And I also want to point out that most doctors these days are overworked, underpaid, sacrificing time with their family, all to provide subpar, hurried healthcare that's not what they dreamed of. When you could be happy, smiling with your patients, which patients notice and they appreciate. You could spend more time with your family. You can even give away a percentage of your care for free. And that feels so, so good. Another argument that I hear is that if all doctors limited their empanelments to 600, imagine how short we would be on primary care. Which, I mean, it's hard enough to convince a doctor of just about anything. No one is seeing an influx of thousands of doctors to DPC. It's a gradual change, and that's good. Because if all doctors gradually became DPC, maybe we finally would have enough doctors. Because no one like me was being told not to be a doctor because it's so miserable. Med students would see happy family medicine doctors with actually good work-life balance. And they'd want to become primary care doctors themselves. And if DPC doctors gave away 10% of their care, which many do, that would make a big dent in the folks that were having difficulty getting health care. And is $55 a month really more than modern folks can afford in the face of smartphones and Amazon? You can also flip the questions. Is it moral and ethical to spend just 7 minutes at a time with every patient? To give patients data away for a profit, as so many large EMRs do? Is it ethical to ever retire? There's still people that need you. Or to become an administrator and see fewer patients? No one ever asks those questions, but they're just as valid. So here I am. I am 1 month into owning my own clinic. This is not where I thought I'd be when I signed up to deliver this talk. But it has truly been God's will. He's guided my every step. I brought more than 100 of my own patients from my last DPC clinic. Every day, one of them or another tells me how proud they are of me. Many of them are entrepreneurs and small business owners. Talk about a group of people that can't afford their own insurance policies, but they appreciate other small businesses. And they know the value of a good relationship. They need to be able to text their doctor on weekends to meet up for some stitches after a small accident on the job. They read articles on social media that they don't really trust, so they can email me and ask me what I think about them. They get it, and they love it. This is not typical for a startup DPC. I kind of cheated by being in a separate DPC for a while. But already I can cover my monthly business expenses with my monthly memberships, and I will slowly build to pay off my startup costs and hopefully in the next year get a salary for myself. It's not pretty right now, but I have great expectations for the future. I can't even describe how cool it is to work for myself. The other day in the survey, I wasn't sure whether to mark whether I was working for a Catholic administration or not. I'm everything. Another concern that I've heard is that this is like concierge medicine. Concierge medicine, for the record, usually takes both insurance and a pretty high monthly membership fee. My fee is much more reasonable, and the exact patients that would have made me groan to see previously, I have seen amazing things happen. So like those highly anxious, hypochondriac patients, usually maybe they got an ER visit the other day for chest pain, and they got full workup in the ER, and it was deemed to be just anxiety, and they come in to talk to me, and these symptoms are real. I really feel this clenching sensation in my chest. I can't breathe. What's going on, doc? I get to put them on a PPI for acid or talk about exercise and mindfulness. But then I get to see them every other week for as long as they want. I've got time. And their symptoms melt away. They finally know, unconsciously or not, that they can be seen whenever they need to be. And that's the cure that no insurance-driven clinic with weeks to months for the next open appointment can replicate. And I see it time and again. As for only taking rich patients, high deductible health insurances costs more over the course of the year than my practice. I have time to help my patients navigate the expensive parts of healthcare, to learn about medication saving with coupons, and all the other tricks that I've learned over the years for saving them money. I can cover 80 to 90% of most people's health care just by practicing to the full extent of my training as a family medicine doctor. I can do the joint injections that I didn't have time for before. I can counsel them on physical therapy. So I can save them those additional specialist visits too. Now, I do still recommend that everyone have health insurance, but for those who can't make it happen, I am helping to help them avoid needing those emergency trips to the ER that can truly bankrupt them. So I also hear about concerns from specialists. Not everyone's a primary care doctor. Dropped, so I heard to see the notes I'm looking for. The first one is easyorthopedics.com. He's an orthopedic hand surgeon in Colorado Springs. Of all the specialists that I would never think could possibly make it, who would be an orthopedic hand specialist. He's been at it for 4 years now. He's doing great. He doesn't even have his own office space. He sees his patients in places like mine, which my patients adore. They just have to go to their own doctor's office and they can see this specialist. And he does most of his surgeries by renting out a surgical space and doing just local. So like for a carpal tunnel release or a trigger finger release, he'll just do a local at the shoulder rather than full anesthesia. Saves a ton of money. Patients really like that. There's a rheumatologist on call.com. The last two are, there we go. There's DSC Alliance, Direct Specialty Care Alliance. There's a group especially for specialists that want to cut insurance out. And the last two are my favorite cash pay surgery centers. For elective surgeries, if you weren't aware, you can sign on to these websites. Say, hey, I need to have my knee replaced. How much is that going to cost? And you can compare a cash price for how much that will be. That will shock you with how low it is compared to what they usually bill insurance. These are my big resources that I really recommend for anyone who wants to know more about this. You can find other DPC practices in your area by going to DPC Mapper or DPC Alliance. DPC Frontier has a huge collection of articles written on DPC. They've got their own conferences and 2 great books. I really like the Doug Frago book, The Official Guide to Starting Your Own Direct Primary Care Practice. Dr. Thomas has some good stuff too. I threw in a couple more slides just to overwhelm you with how many other articles there are about direct primary care that you could look into if you really wanted to. But they're all listed on DVC Frontier because he's the best. There's a lot of it. From all over the place. In fact, the Catholic News Agency just published one in July, which was quite favorable. But I love DPC. I've got my own, there's my website, Homestead Direct Primary Care, and my own personal site. Does anyone have any questions? If you wouldn't mind walking or microphone or, I don't know.
Dr. Langley, thank you so much for speaking with us today.
I just had a question. Do you then charge for a visit on top of the monthly fee?
I don't.
And then it sounded like you intimated that you would just pass along the prices of labs and x-ray that you would negotiate.
Exactly. I get all my profit, really, all my income from those membership fees. Sometimes I charge an enrollment fee, but I took a tip from the local YMCA who's always advertising no enrollment fee for a limited time, and that's what I'm doing so far. So some people charge enrollment fees. I advertise that I do sometimes. And when it comes to steroid injections in your knee or something like that, I charge them for what the catalog costs me, which is usually about $60 for 2 mils. And they appreciate that that's, I mean, it's a couple cents over that to cover shipping, or if I'm giving them some augmentin to take home, it's a 10% upgrade from what I get from Endameds, Meds. There's these big medication wholesalers, and that covers bottles and my time and printing out the label to make it look all nice. But really, I'm trying my best not to nickel and dime them. It all comes from the membership fee, and that's all that I need.
Just a really quick comment to preface my question. I've worked in DPC for 3 years in Wichita, Kansas. Same exact model as you. I absolutely love it. No regrets. The one difference I noticed from what you said was that you text on the weekends. I think the cool thing is you can set that up however you want. We have chosen to only text during business hours. Some DPCs only text after business hours. Some do all the above. For us, since we only text during business hours, if you text us after hours, they get the auto text reply, which says, if you need us right now, please go ahead and call. I'm amazed how I only get maybe 1 call a week, maybe 2, maybe. And if it's non-urgent, please go ahead and email, and I'll reply next business day. So my question, how much have you loved or hated, or both, the texting on the weekends, and how have you set that up?
Thanks for your question. And like Wichita is where so many of the best DPC practices are. I love Atlas EMR. And it's funny, I tell patients this all the time. I don't know if I set myself up for success by talking about with them, but when I have new patients come in, I say, I have the best patients. They understand that this goes straight to my cell phone, and they never abuse it. Isn't that wonderful? You guys are all so great. And I did get one terrible call after hours where it was a patient's boyfriend couldn't stop hiccuping, and she was calling me at 10 at night. But that's really the only time that's happened. So in 4 years, that's not too bad.
That's so funny. I remember having a patient when I was on call as a resident call me to tell me that her tongue's swell or got swollen for some weird reason, and then she called me back to tell me it was better, like 3 in the morning. I was like, thank you. Rachel, could you explain like how you use insurance? You said you still recommend people have it. Is that correct?
That would just be to cover in case of emergencies or surgeries is what I recommend that for. So usually a high deductible plan where they're paying less every month. If something terrible happens, they will have to pay that high deductible, but if it's that bad where they're having an emergency surgery, something like that, it's gonna be worthwhile.
Thank you so much. I guess, yeah, more of a comment here. One thing is, I think as a Catholic physician and now a mom, I've had this, I don't know if this was shared with other women here, you know, thinking to St. John of Mala, I feel like also had some women in the world here thinking, oh, like if she could do it, what's wrong with me, right? This is supposed to be like something so doable. And having the realization that medicine used to be like a DPC is now, right? And the fact that we've come so far from that, if we really do want to get back to being able to do all the things that God's calling us to do, we really do have to look into a different system. So finding out about DPC has been such an answer to prayer, and I just really appreciate that you gave this talk. And then maybe one other resource to add, I recently found out about a podcast called My DPC Story. And so this lady, I forget her name now, you probably remember, but she has her own DPC, and basically, I think she puts out more than one podcast a week of interviewing different people all around the country about how they do their DPCs or DSCs as well. So if people are interested, that's a really cool resource too.
Yeah, her name is Marielle Concepcion. She does My DPC Story, and one of the big things that DPC docs say is if you've seen one DPC, you've seen one DPC. That every DPC is so different in how they structure their fees and how they make their after-hours calls work, and coverage when they're on vacation. They're beautiful.
Well, thank you again for this much-needed talk. It was a good birthday gift for me as well. Thank you. For someone who's never heard of DPC up until this talk, can you tell me where the $55 subscription fee comes from? Have you had to adjust it up or down?
That's a great question, and it's something hotly debated in DPC circles. I follow a lot of Facebook groups of DPC docs, and that's a really interesting source of different ideas, and that is a hot button topic as to how to make your pay structure work. Some people do it by your age, some people do it by family size, you keep adding up. So it's 55 as an average. My actual average is $65 a month per member per month. And it really depends on your area cost of living, what rent is like, so it really has to be personal to you. And from some of the experts that I've heard of that have been in DPC forever, have seen a lot of DPC clinics come and some go. I've heard that the biggest reason that DPC clinics don't succeed is because they put their prices too high, that they weren't able to attract enough patients fast enough at that pay to cover their expenses. So I cheated and I just copied my previous clinic's pay scale because I had so many patients coming over, and lots of DPC clinics agonize over increasing their rates, especially when it's very needed because they're not meeting the expenses that they're needing to cover. So that was, and the number I came out with was kind of random based on some decent numbers, but it's very, very variable based on your population.
Thank you.
Thank you for the very interesting and encouraging talk, especially for younger physicians, not myself. But I'm curious, are most of these DPC practices family practice type settings? I'm an internist, and we attract the more complex, the severe illness, the elderly, the high-cost patients. And do you have any information about the differential in that regard?
Absolutely. I mean, I think there's more family doctors in the country than I'm not actually sure I'm making that up. I definitely know of practices that only do pediatric patients, so they cut you off when you turn 18, and that's an interesting model in that they are constantly having to bring in new patients, but they make it work. And I definitely know of internal medicine that just cover the more complicated patients, and their price is reflective.
Do you mind talking about like group versus solo DPC? Or do you know much about are there groups of like 3+ docs operating DPC together?
100%. There's all sorts of practices out there. There's one in Colorado Springs that has gone for the more like expand, gotta push DPC, gotta make it as much as possible. So they have, I think, 5 clinics. They have, I think, 10 physicians, something like that, a couple PAs and NPs as well. Whereas I think I'm going to be solo, if not maybe 2 or 3 other docs cap. So it really depends on your personality. If you find someone that you work well with, by all means, I mean, work together with them. You always have someone to cover your call so you can go on vacation, and that sets your mind at ease. When I go on vacation, I have another DPC doc in town that's also solo, and so we cover for each other, and that's worked out nicely so far. But it's still a stressful thing. And so it can work either way. I mean, I kind of had a falling out with my clinic, so it seems like we're gonna work out better to be independent, but I definitely know of clinics that are working together, and it's cool, no matter how it works.
I'm just wondering, either your previous practice or what you're going to be doing now, how do you handle with pediatrics and vaccines, or do you have kids in your practice who also have a pediatrician, and kind of like splits the responsibility? How does that work?
I see all of it. You're right. There's a company called Care that was previously supplying my last practice. They make their money somehow on providing, just having on stock, on hand, a whole little mini fridge of pediatric vaccines. And they actually do accept insurance, so I can just scan the little insurance card to their little machine, and that will bill their insurance, which is great. And they also have cash prices that are equal, if not less, to the county health department prices for their vaccines. So that's an option for some DPCs. They told me that I don't have enough patients yet to have that for myself. So right now I'm telling people to go to the county health department, but it's a nice place. So
From one fellow DPC doc to another, congratulations. Welcome to the water's great. I've been doing DPC since 2016, but left my previous practice a year ago to start my own practice, and I just wanted to come in on the pediatrics. Half of my patients are under the age of 21. But I have a very small practice of about 140 patients, so I'll never qualify for Vax Care. I have a local pharmacy, I send in the script for the vaccine, they'll bill it to the patient's insurance, I swing by and pick it up. I do all house calls, so I have no office where I can store vaccines, so it's just much easier for me to go in same day, pick up the vaccine, show up, and I joke, I'm like, today I'm gonna be a vaccine queen and give everybody vaccines, and it's great. It's super convenient for the patients, and giving kids vaccines in their own home is like a much easier sell than trying to get them in the office.
is that a local pharmacy or a CVS or Walgreens?
Local, but I actually got CVS to give me vaccines once because the patient's insurance would only bill CVS. I know, I was shocked. I was like, they're never gonna do it, and they did.
Cool, thanks.
Any other questions for Dr. Lenny? For sure.
I was wondering, what is an average patient panel? I heard you have 140. Yeah, so what, on average, what are DPCs doing?
As I was saying earlier, you see one DPC practice, you see one DPC practice, so you can do whatever you want, which is a little bit scary at first. Most practices, the highest I've seen most practices is 600, and that's usually with 1 or 2 MAs on staff, maybe a full RN. They're expensive though, because they're so worth it. And yeah, and that implies things like that. It's personnel that are your biggest expense, so balancing the number of patients you want to take with the amount of work you want to personally do. So right now, I'm really intrigued by the idea of keeping my numbers pretty low and maybe only coming in, staying home a couple days a week.
That's a good question though. Like if you had a population of 600, what would an average work day look like, or a work week look like for you?
So 600 is a pretty busy day. I mean, that's going to be seeing all 10 patients in a day, which sounds outrageous if you're used to insurance typical numbers, but that's a busy day. And then you're also answering a lot of phone calls, and a lot of emails, and a lot of texts. So it's a busy day. You're not having time to slow down, and that's Monday through Friday. A lot of DPC docs take a half day on Friday, so keep that in mind. So that would be 600 per doctor.
What do you do for EMR? Are you using EMR as well?
There's some specific EMRs just for DPC. They look like Word documents. That's all you need. You're just writing down the things that you want to know for the future. And a lot of DPC doctors are starting to use more AI as their scribe. So right now, I'm getting into this habit where I do my own vitals while I'm talking to the patient with my laptop in the room. Then we have our patient encounter. Then I draw some labs and we're still talking. And by the end of the visit, my note's all done. I just revise it real quick, change a couple of things, and it's already done.
Beautiful.
AI or like voice dictation?
It's AI. So it's taking our conversation. It can tell the difference between my voice and the patient's voice in other languages with multiple people, and it can separate that out and make a note. It's been trained in what a SOAP note should look like. It's wild.
What is that?
That one's, the one I'm using is called Freed.ai. I love that one, FREED.ai. But there's a couple out there.
All right, any other questions at all for Dr. Langley? Thanks again, Rachel, we so appreciate it, it was a great talk.
Thank you so much.